So here's our agenda. We certainly welcome introductions. We're going to talk about objectives. I'm pleased to introduce the three gentlemen here at the front of the room who will be speaking briefly, but we're going to talk about a number of things that are practical approaches. You'll find that we'll start with the gentleman on my far left, on your far right, Chris Shane. Chris is an assistant vice president in the team from McKesson that actually supports our McKesson customers with 340B challenges. Chris works as a full-time consultant as well as providing support to the other team members on the McKesson field and sales teams. Chris has been with us, how many, has it been 5 years now. Chris has been with us 5 years and has been working in the field. We're looking forward. Chris is going to share the insights and things that he's learned as a result of spending all day, every day working on 340B. You guys didn't line up according to the slide, but I'm going to go that way anyway. But I'm gonna, yeah. So good work, curveballs. But I'm going to introduce to my far right here, Greg Niemiec. Greg is a senior managing consultant. Greg's been here about 4 years. Greg comes to us from a variety of health system roles, working as a pharmacy director, and has been with us in the 4 years. We refer to him as he's the engine behind finding out all of the things that you need to do in order to make sure that your program is performing effectively and well. Greg also works as a consultant and works directly with customers, both on engagements, long-term engagements, as well as providing support one-on-one. So certainly you'll get an opportunity to reach out through your McKesson field force to talk to Greg or to Chris or to have them support your questions as they come to the folks that you work with on a day-to-day basis. And finally, we're especially privileged to have Kevin Jones. Kevin is a long-term pharmacy director who thought that it would probably be better to be a 340B guy than a pharmacy director guy, and he's going to tell us probably about how that transition is working for him. But Kevin is a 340B program director for the Intermountain Health System in Utah, and is going to share some of his insights in a large and complex organization, some of the challenges that he's encountered over the past several years of working through that. So with that, I'm going to pass the baton to Chris and let him begin.
Thank you, Andy. Once again, thank you for being here. We really appreciate this. Greg and I will spend the next 20 minutes or so, and obviously Kevin will follow us. But from Greg and I's perspective, our goal is to outline key 340B program strategies, attributes that, from our experience working with other customers, we feel like are often the rate limiting factors that lead to program success. So we'll try to give you some practical tips as we go through here based on, not our incredible knowledge, but really what we see in the field and what we learn from our customers as we help them. So the first section, 340B program accountability. This is a very easy recommendation to make as a consultant, but frankly, I find it one of the most impactful and influential. If you do not have an interdisciplinary team managing 340B at your institution, long-term, I think that spells trouble. And by interdisciplinary, I mean, pharmacy leadership, maybe supply chain leadership, depending on how you're structured. Certainly finance leadership, compliance, legal, informatics, whether that's pharmacy informatics or hospital IT. If you're not meeting on a regular basis with a core 340B group comprised of those types of individuals, your chances of having misses throughout the few years you go through the program increase greatly. A couple of examples from customers we've worked with. Acquisitions and divestitures. Think about it. If you have acquisitions or divestitures of your organization and no one in finance communicates that to the 340B team, certainly the proper updates are not going to be made to your software or data feed. The people in pharmacy are either going to miss out on savings opportunities because of potential acquisitions, or if maybe something moves from reimbursable to non-reimbursable on the cost report, even if it's not fully divested, that can certainly lead to a compliance problem down the road. So having finance not participate in this team, it's going to lead to problems down the road. Charge master updates. We have worked with institutions that unfortunately have gone through whole-scale reviews and rewriting of their finance charge master. Maybe it involves a new financial system, maybe it doesn't. Pharmacy and the 340B program directors are not necessarily involved in that conversation. You'd be surprised. So you can imagine revamping your charge master without thinking about 340B would be a 340B disaster. Medicaid status changes. Once again, unfortunately, we've seen customers where someone in financial leadership or someone in supply chain leadership that may not be tied directly to pharmacy makes a decision. Maybe someone leaves, but they move from carve-in to carve-out or vice versa. That often requires two things. One, a change in how your data feed is built that goes to the software. Without making those changes, you can imagine the problems that would occur. And secondly, in many states, you may have significant changes in the way your finance group needs to bill Medicaid. So we see these things over and over again in hospitals where it's sort of one lone ranger hidden away in the pharmacy that's supposed to manage this whole program without any buy-in from hospital leadership and leaders of other departments. So we feel very strongly about that. From a software perspective, once you've made your software selection, Greg and I consistently see two areas that seem to be the most impactful. And frankly, when we talk about customers that really need significant cleanup 6, 12, 18 months down the road, oftentimes these two areas were not properly addressed up front. So you need to ask the right questions. How do you define a drug? How does your pharmacy system define a drug? How does your charge master finance group define a drug? How does your 340B software vendor define a drug? An example, as you're building these crosswalks, trying to keep track of changes from one generic to another generic and from one package size of a brand product to another package size of a brand product, which might have a slightly different NDC. As you're trying to track all that, I looked up one example before the meeting. Lidocaine. Not lidocaine with epi and lidocaine with just plain lidocaine. If you look in First Data Bank, there are over 600 individual lidocaine products. I cheated. I did lidocaine and lidocaine hydrochloride. So there you go. So over 600 products out there. When you look at how they're grouped according to First Data Bank and Medispan with their generic groupers. So same product, same concentration, same formulation. So it's a spray or it's a topical, 1 or 2% or whatever. Over 60 different generic groupings. Now, I know you don't have 60 charge codes for lidocaine in your finance system, and you don't need 60, but one will not cut it. So one thing we often have customers do is look closely at your charge master up front and compare that with how your software vendor interprets a drug. Because this is not something you want to figure out 3 months into the install, because you might have a 2-month project on your hand to clean it up, and you're going to see a delayed install. So look at that closely up front. The second piece there is how do you accumulate doses for 340B replenishment. There are many options, and oftentimes the best solution really depends on the individual hospital and your combination of pharmacy systems and finance systems. So we have some customers that pull data from a pharmacy system. They pull dispense data from pharmacy. We have other customers that pull only charge data from a financial system. We have other customers that do sort of something in between. They take a little from here and a little from there and maybe use something like an ADT feed to tie the two together. The important point is early in this process, before you start plugging wires in and plugging things into the software, you need to sit down with this team, which would certainly include your informatics group, and say, here's the goal. We need, if we're audited a year from now, if we take data from this system and it says they're an inpatient or an outpatient now, will it look the same 12 months from now when an auditor arrives? And payer status is another great example. And this is where we see a lot of customers have difficulty. If we see in the pharmacy system or in the finance system a certain payer status today, when the auditor arrives and looks at the information system, the hospital information system 6 or 12 months from now, will our data in the software represent reality? Or are changes that are made to payer status and inpatient, outpatient status, are those going to be invisible to our software? All of that really comes back to how you put the data feed together. So those are very critical questions to ask and understand up front. You really have to dig into the weeds up front. And unfortunately, not everyone, we have some customers that haven't done that, and it can buy you trouble down the road. So we feel strongly about those 2 points also. Everyone's favorite topic, 340B and Medicaid, what fun that is. Once again, seems like a soft recommendation, but we absolutely strongly recommend that you have a personal relationship with whoever inside your state Medicaid office understands 340B. We do this for customers all the time. It's not easy, it's not pleasant. You're going to waste some time on the phone trying to find the right person, but eventually you will get to the right people. And I've noticed they fall into two buckets. Oftentimes you will have someone in the state Medicaid office that understands very well how you should bill as a hospital outpatient department 340B items. You will often have another person in the, quote, pharmacy department that understands how you should bill from your retail pharmacy as a 340B provider. And then often there's a separate team that manages all of the rebates, which are critical to you avoiding duplicate discounts. And I can promise you in many states, they never talk to the other people. So you really need to be plugged into all those pieces. You need to understand who decides how hospital billing occurs with 340B, who decides how retail billing occurs, and who understands how the rebates are processed inside your state Medicaid office. You don't want to be the last person at your institution or in your state to find out that 6 or 9 months ago your state produced a nice update to 340B billing in their quarterly bulletin, which you've never seen. So really try hard to keep in touch with your state Medicaid office. The third bullet here, are you carving out Medicaid? This has really been a big topic the last year and a half. Now, there are operational concerns here. In some states, this is easier than others. But we have a number of states where carving in is not terribly difficult. There's not a big reduction in reimbursement. There aren't strenuous requirements. You don't necessarily have to change how you bill from the hospital. So if it's been 3, 4, 5 years since you've looked at Medicaid carve-in or carve-out status, or if you just arrived, you're now the director of pharmacy in charge of this, a 340B program, or at least a part of the 340B program management, and you have no idea why someone chose to carve out 9 years ago, I would recommend taking a look at this. Think about this. If these decisions were made 4 or 5 years ago, what's different now? The GPO exclusion. The GPO exclusion, the much stricter interpretation of the GPO exclusion means that you may be leaving significant dollars on the table with buying all of the Medicaid patients' drugs in the mixed use environments and the infusion center environments and so forth, buying all of those at whack on a non-contract account. So take a look at that if you haven't done that in a while. We see significant, small to medium-sized hospitals, big 6-figure numbers, and certainly with the larger hospitals, sometimes this gets into the 7 figures. So this is something you want to do if you haven't looked at in a while. The last bullet, and this will reach into the next slide. How many Medicaid provider numbers do you have? I can tell you, unfortunately, it's not unusual for us to run into hospital customers when we're brought on site to begin an engagement and really start to dig in and do what they've asked us to do with their program, to determine that they've been carve-in for the last, 3, 5, 7 years, and they provided the state with their hospital Medicaid ID number. No one knew that the retail pharmacy in the lobby has a unique Medicaid ID number that they use to bill the state. That number was never provided to state Medicaid. So in that case, that number was not provided. The state had no idea that they should take those claims and remove them from rebate submission. You have a serious compliance problem and potentially a significant financial problem. So please consider, how many Medicaid numbers do we have? Where do they go? How do they belong? Are we carve in, carve out? Clarify that in your institution and make sure you're not doing something inadvertently. Retail pharmacies. An extension of what we just talked about. Oftentimes when we find issues with Medicaid provider numbers, confusion in the hospital, it usually involves a retail pharmacy that has a unique number. So I think we've covered the potential problem there. I would certainly look into that closely. The second bullet, the Apexis Generics portfolio. McKesson has worked with Apexis over the past few years to develop a pretty comprehensive portfolio now with the WAC account. I can tell you that is critical to the finances of not only the mixed use environment, but really critical for hospitals that own retail pharmacies where a significant number of your prescriptions are not 340B eligible. Unfortunately, we've run into customers that did not realize the impact of old Apexis versus new Apexis. Certainly, It made sense to be a Apexus member in the past. There were subceiling prices. There were prices on vaccines. That's great. In this new environment, though, when you look at a contracted generic price versus true WAC, the stakes are much, much higher. So please don't find yourself running a retail pharmacy where you're buying 20 or 30 or 50% of your drugs on a WAC account and you don't have the Apexus portfolio loaded. So unfortunately, we see that also. And the last bullet, a little bit into operations here. You know, running retail pharmacies is not the core business of many health systems and hospitals. Oftentimes when we're asked to help either do feasibility studies about new pharmacies or to come in and clean up, make recommendations on a current pharmacy, no one knows where the PBM contracts are. No one has any idea how you're being reimbursed. Find those, look at those, make sure you understand who should sign them, who has been signing them, where they're at. Because as a hospital-owned retail pharmacy, you have likely received some significantly reduced reimbursed contracts. There are a handful out there that are 30, 40% reductions from standard retail reimbursement. Now, you may decide to sign those, and that's okay as long as you do it knowingly and it's an informed decision. What we find and what we don't want to happen is you have 4 of those laying in a file cabinet somewhere and you didn't even know it. You didn't make that decision. Someone just signed it, and you've had significant reductions in reimbursement for the past several years. So please look at that closely. That's another gap that we commonly see. Once again, because retail pharmacy is not always our core business in the hospital space. So, contract pharmacy. Boy, we could talk about this for a while, and thankfully, Kevin's going to spend at least 15 minutes on that alone in the next section. So I'll keep this short, but I think it's safe to say at this point, if you're audited by HRSA and they show up and you have either no audit plan or they think you made it up a week before they arrived and you've been in contract pharmacy for 2 years and there's no evidence that you've actually done any auditing other than last week, there's a real risk that you're going to be kicked out of the program. Maybe not the entire program, but certainly they could say, you are no longer participating in contract pharmacy. You will go through a process to convince us that if you reapply, it will be done properly. So if this is big revenue for your institution, no one wants to go to their CFO and say we're going to miss out on X million dollars of revenue because we didn't put a proper audit plan together. So please take a look at that closely. We still run into customers that, frankly, don't really have an audit plan in place, even though they're participating in contract pharmacy. People are getting on board, but there are still some stragglers out there, so don't be one of those, please. And then finally, my last point, software logic, however intricate, and there's some really fabulous stuff out there. There are lots of options. I don't care how intricate the software option is, it's not perfect. And I know Kevin will really dig into this and drive this home, but our recommendation is at least up front, you need to convince your leadership to provide significant resources to audit a large number of prescriptions until you feel very comfortable with the methodology that you've chosen. We just see too many customers that sort of turned it on, said we think it'll work, and now they have a big mess on their hands and they're trying to reverse things. And as I said, Kevin can talk to that to some extent based on what he's done at Intermountain. But please try to avoid that. We would love you as McKesson customers not to have to go through that. So those are the highlights from my perspective, based on, as I said, what we see out there in the 340B community today. Greg is going to take just a couple of minutes to talk about program savings and some of the issues we see with how hospitals do or don't properly assess net 340B program savings. So there you go, Greg.
Thank you, Chris. Again, I want to thank you all for being here. It's great to see a lot of faces that we've already met because we're getting all over the country. So it's good to see you here. And as Chris said, we spend all our time doing this, so we're immersed. And we've learned some things about what questions you should ask. If you look at your 340B software and they present a dashboard with a graph that says you saved this much, do you know that that's how much you saved? Are you trusting that number? Is that the only number you look at? Do you ever get a call from somebody saying, why is your WAC spend so high? And in relationship to your 340B account and your GPO account, your WAC account spend is high. do you understand what that is about and why that number, the WAC spend itself, may not be as important as understanding the premium that you're paying between the WAC price and the GPO price. So there's a lot to learn and a lot to dig into to really understand how to come up with that savings number and that WAC risk. So I'm not going to go in detail because I think I want to hear what Kevin has to say about contract pharmacy, and you can come and see me tomorrow at the booth and I can give you a lot more detail on this. But the bottom line is you've really got to understand the numbers that you have in your software, both your 340B software and your pharmacy wholesaler, and be able to really look at them to balance out and to get to the truth, okay? So that would be my short message. And I'm glad, as I said, we've become spreadsheet nerds since we've been doing this work. And it takes that. And a lot of folks just haven't had a chance yet to figure out, how do I get into the weeds here and figure out, what's going on with savings. So come and see us tomorrow. Kevin was introduced already, but I'll introduce him again from Intermountain Health. He's had some experiences with his program that I think you guys will really learn from, so I'm looking forward to hearing him as well.
Thank you, Greg. Okay. So I'm going to talk a lot about some of the things that Chris and Greg have said, just from a practical standpoint and from the experience that I've had. I was the director of pharmacy at Primary Children's Hospital in Salt Lake for 19 years. Prior to that, I was at one of the smaller community type hospitals. And I got involved in 340B when children's hospitals were added to the 340B program. That was in 2006, but it didn't go live until 2009 or something like that. And we started in early 2010. And my CFO called me up and said, "Hey, we heard about this great program. We want you to do it. We're starting, figure it out because we're starting." And I'm going, "What? I didn't know anything about it." And unfortunately, I learned a lot of the things that I know now with bad experiences. So my goal today is to reiterate some of the stuff that they talked about, and try to, if you haven't already had those experiences, try to give you some advice that might help you stay out of that. My first bullet point there is know your own organization, and I think they talked about that. You've got to know who's involved in the process, who's involved in purchasing, who's involved in setting up the computer system, and how are you going to get your data feeds and what's in those feeds, how are they determined, those sorts of things you need to know. There's a lot of those kind of things you need to know. For example, we had a problem with one particular drug where we ended up not buying it on the right account, and when we started figuring out what was going on with that, we had a buyer in our SCO that looked at our account and said, "Why are you guys buying this at such a high," she didn't say this to us, she just said, "Why are you buying it at such a high price? You got this other price available." So the credit rebuild a bunch of our non-GPO, our non-340B purchases, credit rebuild those back to 340B. And then, a year and a half later, we get this question about these things, and we look back, and sure enough, we had purchased on the wrong account. Well, they had not been taught about 340B. Nobody had given them any information about it. They just thought, wow, my job is to get the best price for the hospital. They saw these accounts and they bought it in the wrong place. So understand who's doing what and how those processes happen, and get to the people that you need to make sure that they understand what your expectation is of them and what the program requires that they do. The split billing and the software kinds of things, we've run into some problems with this, and it ties into what Greg was talking about with WAC. How does your split billing system work? We've had several systems that we've worked with, and many of the systems, once the GPO exclusion was emphasized, we ended up with, you have your accumulator for your 340B items, you have your accumulator for your GPO items, and then everything that's left over falls into this bucket that we call WAC. Well, we had buyers that, and I guess I should give you a little background. We have 11 covered entities, And one of those is a pediatric hospital, 3 of them are DISH, 2 of them are sole community, and the other 5 are critical access. So we get the gamut of this kinds of stuff. And but the way these things work for the hospitals that have the GPO exclusion, they would look at this thing and you'd say, well, why'd you buy all this stuff? Our hospitals varied from 3% WAC to over 50% WAC. And we were going, well, what's going on? And so we'd go to the hospital that had the high WAC and say, why is it? Well, it accumulated there. It accumulated there, so we have to buy it there. And we go, whoa, did you look in there to see what's in there? And we had a problem with really interpreting what was a covered outpatient drug. You should have a policy for that. Be sure you're very clear on that, because there were a lot of stuff that we were buying on those WAC accounts at higher prices that weren't even considered covered drugs, or they were bundled or whatever. So you need to make your decisions about what you're going to include and make it defensible, and then have that policy out there so that you can so people know what to do. So we've rummaged through that, and we eliminated from that percentages things that we were buying from the prime vendor that we were actually getting better prices on. And we're still, that site was still at 25-30% WAC because of the way that it was accumulating. Because if you have something, and if your accumulators aren't accurate, and you under accumulate, that's not really a problem because you're buying it on WAC. But you're spending a lot more money than you have to. So the question is how to do that. And we've had to go through and set up some ways to monitor that. The other thing that hit us, like I say, we've got 7 hospitals that fit in the ACA category, and the orphan drug thing can be a real problem. And when we first, with all of the things, and I'm not going to go into history, most of you have probably heard that, with the rule from OPA, and then the challenge by pharma, and back and forth and back and forth and back and forth. And we saw some significant reductions in our savings because we weren't getting the 340B price on things. And we had selected on all of our sites that we were going to try to get the discount on those drugs when they're not used for their orphan indication. And going through the data, our small little hospitals, they're out in the boonies. They're less than 20 beds. There's one out in Delta that's 50 miles from anything else. And if you go west, you got to go all the way to Reno to get any size town, and that's a couple hundred miles. So they're way out there. All those kind of things. They don't see very many patients with orphan indication drugs. Most of the stuff they're going to see is the mainline indications and those sorts of things. And so we were trying to work through that. And one of the things we discovered was, and I think there's been some talk, HRSA has been trying to work with wholesalers. Some of the wholesalers started blocking the orphan drugs on their own without necessarily having direction from the manufacturers. And the different wholesalers, the major wholesalers, took different stances on that. Some of them said, well, if we haven't been told by the manufacturer that it's okay to give the 340B price on orphan drugs, then we're not going to give it. Other wholesalers said, well, as long as we haven't been told that we can't give it, we'll give it. And so we discovered that we had a mix of those kind of things going on, especially with items that we were getting, biologicals and plasma kinds of things. We're having a real problem with that. And so we changed suppliers for that and went to one that would give us the discount. Now, I'm not going to mention any names, but one of the wholesalers has been pretty good about giving us the discounts. So, no, I'm not mentioning any names. But we ended up having to vote with our feet. Now, one of the other things that I would say about that is if you're in that situation, go ahead and when you have an item that you would like to purchase and you think that you should be able to because you're not using it for an orphan indication, order it that way. Because my concern is, and I think there's others out there with the same concern, is if we finally get to the end of this and HRSA wins out and says, okay, because they've already asked the manufacturers to have a plan for how they're going to reimburse people. But if you get down that road and then you say, well, they say, well, you never tried to order it on 340B, so how do we know that you really were going to get it on 340B? So if you've gone through the process and you've used Apexis has a report form that you can report that to say we're not getting the discount. A lot of that stuff they're going to know, but it will put you in a position where when they finally resolve that, if they end up paying back the hospitals, then you'll be in a position to say, this is how much that you owe me. So that, or you owe the hospital. So that's some advice that I would give. Contract pharmacy. This has really been our Achilles heel. We started out at 5 sites with contract pharmacy, and things seemed to go good. Our software provider came in and said, this is how you do it, and set it all up, and everything was cool. And about 6-7 months later, we got a HRSA audit at one of the sites. And so we started getting ready for that audit, so we were scrambling to do that. And we discovered that we had a large amount of claims in there that weren't proper. We had patients that, because one of the problems we have with the way, and this is why I say know your organization, we have 700, 800 employed physicians, and they're scattered out between all the hospitals and those sorts of things. But many of those physicians are employed by our physician division, our medical group, and they are not, those medical group clinics and things are not on the cost report for the individual hospitals. So you get these doctors, they work in the hospital one day, they're back in their clinic, the patients are maybe on our health plan, they do all their stuff between the different clinics and the hospitals, but then you find out, well, that was related to the clinic visit that's not on the cost report, this is the hospital, and then you end up with claims that are not right. And so we had about a 70% rate of bad claims. And I'm going, you can't fix that. The only way you can fix that is report and pay back manufacturers. So here we had this audit coming. So we decided, okay, this was in November, and the auditor didn't come till January. So we self-reported to HRSA, said, hey, we've got this problem, et cetera, et cetera. We gave them a corrective action plan and went from there. And of course, when we had our audit, and the interesting thing is that like I say, it didn't involve just that one site. There was 5 sites involved. So we did that process at all 5 sites. And at the other sites, currently, we're still working on that a year later. 2 of the sites, we've gotten letters back from OPA saying they consider the matter closed. We're able to get everything done. Other sites we're still working on, and with the audit, we didn't get our audit report until December. And so we've now submitted the follow-up kind of documentation for that. And we got one finding, and that finding was diversion. Well, we pretty much knew that was going to happen. But they said, yeah, nice try, guys. We know you self-reported it. We appreciate you self-reporting that, but it was 17 days after we gave you notice. And we're going, okay. And so it's like, okay, we understand that. And then they gave us 2 recommendations. One was to have in our policy more information about how we're going to prevent diversion. They wanted to see a more robust kind of information in there. The other thing that they wanted to see is they said, well, you've got some pretty good policies about how you're going to monitor your contract pharmacy, but you didn't do it. And obviously, if you'd have done it, you probably would have caught this much sooner than you did. So you need to go back, review those policies, et cetera. The nice thing about recommendations, you don't have to respond to those. It's just the findings that you have to respond to. So what we did, we shut off our contract pharmacy completely. We figured out how much harm we'd done to the manufacturers. We sent letters to all the manufacturers explaining that we'd had a problem, and then asked them to contact us about that. We sent one letter, and then 4 months later, we sent another letter to all the ones that hadn't responded. At this point in time, we've had about a 45% response rate from those letters. And out of those, about 70% of those have requested to be reimbursed for it. So, and I think that a good point, and one of the things that you'll hear other people saying, the prime vendors saying, is, don't just send back manufacturers checks or things like that, because they may not want to be reversed. They may want more information. They may think it's worse than what you thought. We've had manufacturers that we owed, like $8,000, and said, hey, don't worry about it. And we've had others that said, you owe us $25. Well, I want that check by next week. And so it's variable. And I think my impression of what HRSA wants is they want you to work that out as much as you can with the manufacturers, and that everything is cool. And then, of course, you would report it to them if it's something that you determine at your site that is material or not. So anyway, so we've turned it off. Now we turned it back on at one site, and we turned it on with 3 doctors in one clinic, and we've been auditing every claim, and we've been running about 300 or 400 claims a month with those three doctors, and we've found about 3-4 a month that are bad claims. And we thought this was really tight. We were still getting bad claims, and not very many. But you say, well, it's not very high. But you got to remember that when HRSA comes to do an audit, they'll say, give us 6 months worth of data. So you'd give them everything you did for 6 months, and they picked out 70 claims. 30 of those were for us. 30 of those were contract pharmacy. And if one of those is bad, you have a finding. One claim bad, you've got a finding. So I don't know if you want to take the risk on having 3 or 4 bad ones out there or not. What we're doing is we're going to have a very high, and right now we're looking at all of them, and as we move forward, we're going to have a very high rate of reviewing those claims, so that we can try to eliminate anything that might be bad. And hopefully, as we go along, we've seen a couple of trends already. We can work to correct those trends and then not have to do as much auditing. But my advice on contract pharmacy is be conservative and audit, and when you get done doing that, audit. And so to make sure that you don't have those kinds of things. And what the kinds of things that we audit is we audit to make sure that the patient actually had a visit at the hospital, that the claim that we had that we processed was somewhere close enough to that visit that you would think that it was related to that visit. We check to make sure that the physician is, what the relationship is between the covered entity and the physician, and then we look at how the drugs accumulate to make sure that that's correct. Because we had situations where a patient would, on these bad claims that we had all kinds of them. Some of the worst ones were things like a patient would come in for a mammogram. Their doctor who worked for the hospital sent them over, and so that was a visit. And then they went to the clinic, to the same doctor, and got meds for their high blood pressure or whatever. We failed those prescriptions and called them 340B prescriptions, but the reason for the visit didn't match. And so that's another thing, and trying to work with software vendors to try to to do diagnosis bridges and those kinds of things to see that we can do that. And we're working with that, but like I say, we're not doing a lot right now, and we're getting ready to ramp that up. So I think pretty much covered the things that are on there. So we'll open it up for questions and go from there.
Thank you, Kevin. Appreciate all 3 of you sharing your insights.